So, this is the video of laparoscopic Heller's cardiomyotomy in a early sigmoid esophagus. The patient got dilated tortuous, you can see the CT, tortuous is going on right side and then it is going on left side also. So, it is a dilated tortuous early sigmoid configuration of esophagus, and this is this view also will be shown a little bit sigmoid portion, and manometry shows type 2 achalasia cardia. I am planning for laparoscopic Heller's cardiomyotomy. So, I have to mobilize the esophagus, I have to straighten the esophagus first, then I can do the myotomy. So, always the dilated tortuous esophagus, the straightening of esophagus is the key factor for success of surgery. We have to take utmost care to straighten the esophagus. So, this port is like a usual port, 5 port, one 10 mm camera, all others are 5 mm, 4 5 mm working port, 2 port for 2 hand working, one is for liver retractor, this is for stomach retraction. So, these are all standard port. Approach is also same approach. Open the gastrohepatic omentum, and then this patient also is having looks like accessory hepatic artery. So, I am planning to preserve this artery. You can see it is a little big artery. So, always this is better. So, that is why the CT I am taking for all upper GI cases, particularly achalasia and this one fundoplication GRD cases. So, mainly for anatomy, vascular anatomy is normal or not. So, artery is preserved, then I am opening the peritoneum covering on the esophagus. So, this is the crus, right crus, attachment of the fat is being separated. Exposure will be difficult in case of this accessory artery. So, once you enter the hiatus, then you can do dissection from above. So, we have to careful about the postvagus now. So, that is the first structure when you are entering the hiatus. So, that is the pleura. So I'm checking for anterior vagus. So, I press the anterior vagus and the esophagus with my right hand. You can very well see the anterior vagus. You can see it very well, and I'm dividing the phrenosophageal membrane. So, always your left hand instrument should protect the vagus, that is the vagus. So, you have to protect the vagus. So, we should not be injured, no, at any cost. So, otherwise the patient will have gastroparesis and motor dysfunction. So, I am entering into the hiatus now. We have to do extensive dissection in case of the sigmoid esophagus or early sigmoid esophagus, and it will be dilated one. Second thing is more of pleura will be adherent to the entire surface of esophagus. So, we have to careful about the pleural separation. It should not injure. Even if injure, no problem, we have to separate. So, we try to preserve the pleura without any injury. And posterior vagus also will be tortuous course, and because of the long standing that also will be stretched. So, now I enter the hiatus, you can see the pleura down, and the below is the pleura, and vagus now is also seen. So, what I am holding with my right hand is the pleura. So, I introduced the liver retractor into the hiatus. So, it is retracting the crura now. So, I am just checking, and vagus you can see it is very easily, chance to injury is very easy in case of this dilated tortuous esophagus, that is the post vagus. And you can see the lung, it is a right pleura, very thin pleura, stretched out, very thin pleura. Lung is seen nicely, transparent pleura, and there is no injury. I am just pushing out, and you can see the vagus now is going like this. We have to mobilize the right side of the esophagus and posterior side, left side, then anterior, so that then only it becomes straight. You can see my camera, instrument, everything is going inside the hiatus, almost around 6, 7, 10 centimeter from the uh, hiatal opening, almost 10 centimeter I am dissecting. Sometime in this type of dissection, I used to take a 0-degree telescope instead of 30-degree. 0-degree will give end view, so that transhiatal dissection will be easier with 0-degree. So now I am coming on the left side, right side already done. I am coming on the left side. This is the anterior dissection. Any vessel is there, you have to coagulate, otherwise you can push like this, it will go. And you cannot hold the esophagus. You can say I with the open, my left hand instrument is open and then pressing down the esophagus. So simultaneously anterior and left side dissection is being done now. Here also we have to careful about the left pleura. So once you dissect both side and then anterior and posterior, then the esophagus becomes straight. Then you can start myotomy. So now you can see, I am straightening the esophagus. So this what little bit sigmoid configuration. It is going on left side. Now you can see the roomy space on the left side of the esophagus. That is a left mediastinal space, and these are all the vessels. From aorta, it's supplying the esophagus. I am dividing with the harmonic scalpel. Aorta also is seen nicely, thoracic aorta. So from left side, I enter posterior, left posterior. So all the space is being additions is separated. Again, I am coming to the anterior surface of esophagus. You can see now how much wide space, uh, wide esophagus. So coming on the right side. So right side is done. So we have to do little bit on posterior side. So that the post attachment is gone means then if you pull the esophagus, it will become straight. You can see how much densely adherent pleura to the esophagus, and esophagus is so dilated. So that is the vagus. Along with the vagus, I retract the esophagus. I am doing a posterior separation now. So in tortuous, dilated, and sigmoid esophagus, sigmoid esophagus is straight away surgeons are doing a esophagectomy, and if it is a early sigmoid and diameter is less than 6 centimeter, transverse diameter, according to Japanese classification, 6 centimeter less than 6. So we can do large myotomy, long myotomy, not large, long myotomy, more than 12 centimeter length of myotomy we have to do. So 50% of patient will benefit with the surgery. There is no need for esophagectomy. If it is not, if it is again the symptomatic, then that is the thoracic aorta. If it is a symptomatic, then we can go for esophagectomy at any time. And major surgeries, again morbidity is there. So this is the better procedure. Since we are straightening the esophagus and then we are doing a long myotomy, the results are better. So, still the posterior inferior phrenic phrenoesophageal membrane attachment is there. So, without injury to the vagus, esophagus is retracted. Once you divide this, then your esophageal mobilization is circumferentially completed on the overside. So, it is completed now. A small bit of tissue is there. It is a very thick, white transparent layer. It's easy. It's a strong layer. Phrenoesophageal is strong. So, it is like a cap covering the, otherwise called inferior diaphragmatic fascia. It is like a cap, the covering the hiatus opening. It is same like chest also. There is superior diaphragmatic fascia is there. So, once it completes, then I can go for a. So, that is a post vagus, enter vagus. I am checking inside. So, it's confirmed. It's straightened done, and I am going for a anterior vagus mobilization. So, all the steps are same. Almost I am showing. This is the, I think it's a fourth video. Steps are same. I'm not changing the step, but the presentation is different. And even though it is a dilated manometry shows type 2 achalasia, always type 2 achalasia the result is better than type 1 and type 3. Type 2 is around 80% or sometimes 90% I can say, and type 1 will be around 60 to 70%, and type 3 is 50 or less than 50%. They will be symptom free only 50% of the patient. So, that is why this patient, even though it is a type 2, but it is a early sigmoid configuration, dilated esophagus, tortuosity is there. So, definitely I have to make straight in the esophagus and then long myotomy. So, that will be helpful for the patient. So, that is the vagus. So, I am mobilizing the anterior vagus. So, when you are mobilizing it, I can open the one layer, thin layer covering the esophagus, so that the longitudinal muscle I can see very badly. So, myotomy is easier. You can see, branch of vagus is going curved and then it's going like that. Multiple branches seen in this case for anterior vagus. So, I am opening it. I'm doing it on the other side now. So, this is the covering membrane. It is not a myotomy. If you are not taking this membrane, so you will have more force to open this membrane when you are doing myotomy. So, that is why this covering membrane should be removed, so that your muscle will get badly seen. So, it is easy to start myotomy. Say, I want to long myotomy, that's why I went so much inside the mediastinum. So, before starting myotomy, I have to mobilize the gastric fundus. So, once the myotomy is done, we should not do all those steps. So, chance of injury to the mucosa will be there. So, that's why all the steps to be done before starting the myotomy. So, this is the gastric fundus mobilization. I am planning for two-pay fundoplication. So that now I mobilize the esophagus circumferentially. So, I am planning for two-pay fundoplication. So, this is attachment to the pancreas, it is being separated. Okay. So, I am going to check whether the mobilization is adequate or not, otherwise I can release some more post-adhesions. So, it is adequate. Susan is also done. I feel little tension, so I am just checking here. These are all the post attachment to the pancreas. I am releasing the some of the around 1 to 2 centimeter in the posterior side. That will make more tension free fundoplication. So now we can able to appreciate it is going to other side, the fundus, pancreas is in nicely. So once I take the fundus inside, if you leave it, it is staying there. So I am going to start the myotomy. So already around 3 centimeter length of so 3 to 4, almost 5 centimeter from OG junction, the peritoneum got opened. So it is easy for myotomy. So always the myotomy should start above the level of OG junction 1 to 2 centimeter, and after completion of lower esophageal myotomy, then we can come to OG junction, then we start a gastric myotomy. So you can see I am using a 2 Maryland forceps. I am just applying cautery for longitudinal muscle, because longitudinal muscle is having a blood supply. Circular muscle does not have blood supply, very rare, once in 3-4 centimeter distance. So, it will not bleed when you are dividing the circular muscle, but longitudinal muscle we have to coagulate and then separate. So, this is the separation of longitudinal. Now, you can see around 4-5 centimeter longitudinal muscle I separated. I am not starting a circular muscle division, only I am separating a longitudinal muscle. So, now I am starting the circular muscle division. So, I am starting division of the circular muscle, and here I am not using cautery. I separate the circular muscle from the mucosa or submucosa, and then I am just tearing the muscle, tearing the muscle with 2 instruments, and most of the time there will not be any bleeding. If it is any bleeding, you can coagulate. Usually blood supply will be there within 3-4 centimeter distance. So, it is basically submucosa and the muscle between the circular muscle I am going. So, now I am introducing the liver retractor for instrument into the hiatus. So, again I am doing a longitudinal muscle separation, then I can go for a myotomy. So, first separate the longitudinal muscle, so that the circular muscle will be exposed, then separate the circular muscle from the mucosa, then tear the muscle. So, this will help you a lot. So, myotomy is easier, there will not be any mucosal injury. You can see another 5 centimeter or 6 centimeter distance I went up. So, I am not going very close to the mucosa, it is a submucosa of the esophagus. So, I am going in a submucosal plane, thin layer is covering the mucosa, so that it is like a poem plane, no? Poem they went into submucosa, same plane. Very thick muscle, I am separating in 2-3 attempt. So, again I am going for a longitudinal muscle separation. So, I am aim for I aim for a long myotomy, since it is a dilated early sigmoid configuration of esophagus. So I am not using a sugar baker, modified sugar baker or Achilles scissor designed by Palnivellu sir now. Initially I started using it. That is a 10 mm instrument. We have to make a port 10 mm, and they have a 7 mm also. The companies are making a 7 mm also. But 7 mm the coverage is not adequate. The insulation on the lower blade will not be adequate. So always 10 mm is better. So now we can see here is more than 10 centimeter length of myotomy is done on the esophagus. So now I am coming on, so I am just showing this. So now I am coming on the towards the OG junction. When I come close to the OG junction, so I am just expanding the space by both is just I am moving it. So that is like a anterior 180-degree muscle division will be there. So up to call stores, it is a 5 centimeter. The letter from tip of the instrument to K, 5 centimeter, almost 10 centimeter done. So I retract the nerve on the other side. Now I am coming on the OG junction. Here the oblique fibers will be there. So we cannot separate longitudinal and circular like in OG junction or stomach. These are all oblique fibers. We may just mark, separate the one layer, and then hold the layer and then separate. It's need not to hold the muscle and then division is not required. When you separating the muscle, so that thin muscle also will be divided automatically. So now I am coming on the stomach side. The traction we are giving with the both Maryland, some tissues would separate. If your not tissue is not separating with traction, then it will be you are holding like a thick or there is no muscle is there. So don't give more force; it will injure the mucosa. So the muscle will get tagged with minimum force, and it's not a very thick muscle. It's a regular muscle only, but the function relaxation function is not there. That's why it is always produce dysphagia. So now I am on gastric side. It is around almost 3 centimeter gastric myotomy I have done for this case. So it's more than 3 centimeter was done. So that area, that is a vessel. If it is vessel is there, you have to be very careful. If a vessel is injured, you cannot control, because if you apply cautery, it will go to the mucosa. And if a vessel is there, you cannot separate also. So try to separate on lateral side, not on the central side. So it is all the muscle fibers are divided. I hold the muscle fiber, identifying it with a fiber by fiber, I divided it. So it is a long myotomy, around 15 centimeter is done for this patient. I am taking a tape of 15 centimeter length. I am just now you can see now how much inside it was done. So it is a 15 centimeter length of myotomy. 15 centimeter length of myotomy is done. So now we have to go for 2-pay fundoplication. So now the myotomy length is like this. So I am going for a 2-pay fundoplication now. So Ryle tube is being pushed inside. And many surgeons, they are not keeping a Ryle tube, but my practice is keeping the Ryle tube. For one day I keep the patient nil oral, that is the first POD. Second POD I do the gastrographin study. Then I allow for a clear liquids around 30-40 ml. And from third day onwards I allow for a liquid diet for 2 days, then semi-solid for 2 days. From fifth day normal diet. So after introducing a Ryle tube into the stomach, I am going for a check for a air leak test. So air is water is placed and the air is injected. You can see the air is injected and there is no leak. There is no injury to the mucosa. So this is a simple test. There is no need for endoscopy. So first I am taking the anterior fundus, posterior fundus on the right side, and I have to fix to the right side divided muscle 3 suture, and then left side 3 suture, and then I fix the fundus to the right crest. So totally 7 suture I used to make it. That is same thing I am showing in other videos. So I am not showing fully for this video. So only one side I am going to show. So the excess tissue is trimmed. So I am taking the fundus between the vagus and the anterior vagus and the esophagus on the right side. So I am taking a stitch. So this is the polyester stitch, or otherwise called ethibond suture 2-0 material, and 3 suture I used to take with 1 centimeter gap for a posterior 2-pay. This is 180-degree 2-pay fundoplication, posterior 2-pay fundoplication. So thick suture taken on the esophageal divided muscle on the right side, and then posterior wall of fundus. So the same thing will be repeated on the left side, and we fix the wrap to the right crest. So that ends the procedure. So this is the way 3 stitch I am taking on the left side for a posterior 2-pay fundoplication. Thank you.